here today, and thank you for attending. I'm here to speak to you about monitoring bivalvuline using a thrombin inhibition assay. My name is Sri Cheriku. I'm a cardiac anesthesiologist, cardiac intensivist with UT Southwestern Medical Center in Dallas. So bivalvuline is becoming more used throughout the United States and throughout the world. It's an alternative anticoagulant to heparin for patients who are supported by ECMO. Although PTT is most commonly used for monitoring the therapeutic effect of bivalvuline, it often shows a poor dose-response relationship because of assay limitations which make titration difficult. These limitations increase the risk of over or under anticoagulation and can lead to more bleeding or thrombosis. A bivalvuline-specific chromogenic thrombin assay, or anti-2A assay, provides direct measurement of drug concentration and may improve anticoagulation management. So this is a retrospective study, a cohort study performed at UT Southwestern Medical Center, large academic medical center in Dallas. So we compared patients who received bivalvuline and they had their levels monitored using either activated PTT or the chromogenic anti-2A assay. And the outcomes we looked at were how long does a patient spend in therapeutic range, how often do we have to adjust the dose, and how often do we have to monitor the level of this assay in the laboratory, and what are the clinical outcomes. So we have here our table 1, which shows that there is no difference in demographics between the two groups. We happen to have better kidney function in the APTT group, and we happen to have more VA ECMO patients in the anti-2A group and more VV ECMO patients in the APTT group. And this is because of, I think, practice differences between our VA ECMO and VV ECMO patients. Our patients who were monitored using this thrombin inhibition assay or anti-2A assay achieved time within the therapeutic range much more consistently, and this was statistically significant. They were also faster to reach therapeutic range, typically within the 12-hour period, than those monitored by APTT. So what we found additionally as part of our secondary outcomes was that the anti-2A assay was associated with fewer dose adjustments and fewer laboratory tests. So in conclusion, compared to the activated PTT, the bivalvuline-specific anti-2A assay improved therapeutic targeting and reduced the monitoring burden in ECMO patients receiving bivalvuline. These findings suggest that using a chromogenic anti-2A assay may improve anticoagulation management in this high-risk population. Thank you for listening.